quite strange compared to the rest of the world in that the use of warfarin is increasing in the UK, not in the rest of the world.
Terry, thank you very much. So I've been asked to give an update on some of the trial evidence, and that's what I'm going to set out to do. These are my disclosures, and I have been involved in various guidelines, but not in the field of atrial fibrillation, and the relevant disclosure is in relation to the ROCKET trial where I was co-principal investigator. So here's the systematic overview that shows that anticoagulants are underused in stroke prevention in AF. And if you simply look across the years, you can see overall the underuse, but you can also see that in the top, I'm showing in grey the high-risk patients, and it's still substantially underused over the course of time. Now, you might say that our colleagues in North America do this a lot better. Well, do they? This is from the US NABOR study, and what it tells us is that if you divide the patients into different risk categories based upon prior stroke and many of the factors that Greg Lipp's been talking about, you can see that the over a quarter, no treatment at all, some on aspirin alone, some on warfarin aspirin, and green at the bottom is warfarin alone. And please look at the high-risk group. You can see no greater proportion were treated with anticoagulants in the high risk than low risk. Next, you can ask the question, well, they've gone over the hurdle, they've got started on anticoagulation, how well is this tolerated? And this is from Elaine Heilig's work, and she looked at the rate at which they were taken off therapy per 100 patient years. And the absolute numbers are shown here, the rate per 100 patient years, according to the old-fashioned risk score. And you can see that in the higher risk categories, about a third were taken off. But the scary statistic is that 58% of the time only they're in the therapeutic range. And the treatments are not benign. Take a look. Major hemorrhage, 7%. Intracranial hemorrhage, 2.5%. And the rates are nearly threefold higher in those over 80, the population that with most prevalence of atrial fibrillation. Another scary statistic, 28% discontinued at a year. So they got in, they got treated, 28% discontinued. Why? Well, I'm not going to ask Tony Hegarty here because he could tell us all of the drugs that are on this list and this list and this list, and I've saved you from some of the others that are in prescribing as to those that interact with warfarin. To simplify, it's a long list. And it's a challenge because people, as we know, don't always take the same dose of the same drug. And also, they vary their diet. And here I'm showing you the foods that contain more than 60% of the daily value of vitamin K. And this is the NIH warning. So if you like your Brussels sprouts or your turnip or your kale or you must have to eat a lot of parsley, but it's got a lot of vitamin K in it. And even some things that I had never realized, like turmeric, it's got high amounts of vitamin K in it. So varying your diet, an older patient with all the challenges there are, challenges with diet interactions, with drug interactions. So ideally what we want is something that is simpler, with a predictable half-life, that one doesn't have to monitor and adjust every day, and a stable, predictable metabolism. We haven't achieved any of these perfections, but this is the desirable set of goals. And what's different about the new agents, and I'm here showing you on the left-hand side of the screen, the agents that work via 10A, factor 10A, and the agents that work downstream against thrombin, like dabigatran, obviously 2A. And the amplification between here and here is 10,000. So working upstream is quite an effective way of doing this. There's a lot of trials. And as Terry said, there's a huge number of trials in this area. And some of the trials are, one of them, testing for superiority in people that either said they couldn't take warfarin or the clinician said they couldn't take it. The others are non-inferiority. Why? Because when you give the warfarin, it's effective. It reduces stroke rates by 2/3 compared to placebo. So the first trial I'm going to discuss is the Averroes trial, and this is in individuals who were demonstrated or expected to be unsuitable for vitamin K antagonists. That's a tricky one, because either the patient or their clinician said, "Oh no, Mr. Jones, I don't think you can manage this." And perhaps Mr. Jones could have managed warfarin anticoagulation. And what they did is they randomized these individuals to aspirin against one of the novel anticoagulants, Apixaban, an anti-10A inhibitor. And the primary outcome was stroke or systemic embolic event. And the results are very interesting and entirely in keeping with what Greg Lipp's just been talking about. First of all, there is a dramatic and very different outcome rate, a halving of the event rates, risk reduction 0.46, compared to aspirin. So those of your colleagues who say, actually, I'm worried about bleeding, and aspirin's pretty good anyway, two messages. Aspirin is not as good, halving of the rate with a novel agent. And secondly, the bleeding rate is no better with aspirin. So the concept that there are many of these people with atrial fibrillation in the community treated on aspirin alone, I think we're doing our patients a disservice. Many of these, I think, could tolerate some form of anticoagulation. And now come on to the RELY trial. This is an interesting design because part of it was open. All of the patients and the clinicians knew whether they were on warfarin or a dose of dabigatran. This is the anti-2A, the direct thrombin antagonist. They just didn't know which dose. And what the trial showed is a very interesting finding. It showed that if you used a low dose of dabigatran, you did as well as warfarin. If you used a high dose, 150 milligrams twice a day, both of these twice a day, you had superiority compared to warfarin. And these were people in the old CHADS-2 score of 2. So they were at risk. What you can also see from these data from RELY is that major hemorrhage steps up, with the highest rate being on warfarin, and then the dabigatran high dose, dabigatran lower dose, and then intracranial hemorrhage. So one of the messages to take home from today is the new agents are less bad than warfarin at intracranial hemorrhage. All of them approximately half the rate of intracranial hemorrhage. And if for your patient or your aunt or your grandmother reducing the rate of intracranial hemorrhage is important, then maybe this is something we need to think about. And this fits in entirely with the risk characteristics that Greg's been talking about. Here is the information on stroke and systemic embolism by the old-fashioned CHADS-2 score, and obviously it steps up, but so does major bleeding. So both bleeding and stroke risk increasing. But as Greg has showed you, the net clinical benefit still exists even among those by higher a has-bled score at bleeding risk. So there's another very important take-home from that. So this is ischemic and unspecified stroke, and the high dose of dabigatran was better than warfarin or the low dose of dabigatran. This is the rate of hemorrhagic stroke, and both of the doses or the other new agents are better than warfarin. What about side effects? Here's the rate of bleeding and myocardial infarction. And bleeding, I won't go in the interest of time into all of the details, but what you can see is essentially the lower dose had consistently lower rates of bleeding, whereas the higher dose was somewhat similar to warfarin. There was a concern about myocardial infarction, and the data from the original presentation and publication showed a hazard ratio for myocardial infarction which was concerning that there may be an excess. And when those investigators did an adjustment for baseline characteristics, they don't feel that there is still much of an excess. However, others have pooled all of the studies of direct thrombin antagonists, and there are trends for an excess in myocardial infarction, and we can maybe discuss that in the discussion time. The other thing to think about if your patients are being prescribed these agents is there is more dyspepsia. It's about twofold higher than for warfarin. As I said, I was involved in the Rocket AF trial. This is a little different from the other. It's different, first of all, from RELY, double-blind, double-dummy study. Secondly, these were higher risk. In the old-fashioned CHADS 2 score, 3.5. So these are substantial risk. Please look at the rate of congestive heart failure, 63%, hypertension, 90%, prior stroke, 55%. So you could argue about half of this was secondary prevention. What we showed in the trial was that the trial met the criteria that it set out in terms of non-inferiority. So it satisfied, however you analyze the data, the criteria for non-inferiority with a hazard ratio of 0.79 and confidence bounds 0.66 to 0.96. While you were taking the drug, and for 48 hours after, there was a significant difference in favor of the drug. But I'll come to this, because there's some things that in retrospect we should have done differently in the trial. And this is it. We were far too cautious about bleeding. The NIH said, you're going to get bleeding. Be very wary about double dosing at the end of the trial. And we were too cautious. It took a median of 13 days in the rivaroxaban arm to bring the patient, start them on warfarin, and bring them up to therapeutic levels. In the reference warfarin arm, of course, they continued. So they didn't have that same problem. So in retrospect, this is something we did wrong. And this is the evidence why we did it wrong. So if you look at the event rates while individuals were on treatment, in the warfarin arm, 243 strokes and non-systemic embolism events, 189 for rivaroxaban, but afterwards there was an excess, 80 versus 63. So the confidence bounds are separate here, they overlap. So the most purest interpretation, it is as good, but not better than the reference. Aristotle trial is another anti-10A. It's dosed twice a day rather than once a day, but has many similar characteristics to rivaroxaban. Very interesting results. Hazard ratio 0.79, which is the same as seen in the Rocket trial, exactly the same confidence bounds, a significant benefit, and also different from the Rocket trial, a reduction in bleeding. Now, interestingly, subsequent to the original publication, the Aristotle investigators have presented and published some of these data as to what happened at the beginning and the end of the trial. So at the beginning of the trial, those who were warfarin experienced and carried on and randomized to warfarin had an event rate of 1.4% per year. Those who were warfarin naive and went on to warfarin, 5.4. What does that say? When you're getting started, it's difficult, and there's an excess hazard. What about at the end of the trial? At the end of the trial, those on warfarin going on to warfarin, about 1%, which is what we saw, and those on Apixaban going to open-label treatment 4 times higher. The only difference is we included all of these in our analyses to be as inclusive as possible in the ROCKET trial, which, you know, the analysis here stopped a little differently. One more thing to consider. These agents are not the same in terms of their renal clearance. So I'm showing you in this slide the impact of mild, moderate, or severe renal dysfunction as reflected by creatinine clearance. And the data are shown down below, but essentially Apixaban and rivaroxaban are rather similar. Dabigatran, be wary of severe renal dysfunction. I come back to the guidelines, and the guidelines have clearly said these particular guidelines from the ESC predated the very recent approval of Apixaban. Almost certainly the update will include that in the novel anticoagulants. So they show that these are the recommendations in relation to rivaroxaban, to dabigatran, and as Greg said, we need a simplification that says that unless you've got a CHADS VAS score of 0, you need a form of anticoagulation. And that really is the key take-home message. And the second message is aspirin is not as good as we thought it was. So before we open for discussion, I hope you're convinced that atrial fibrillation is undertreated, and even when they get started, they come off internationally. Apixaban is clearly better than aspirin in those unable to take warfarin. Dabigatran, rivaroxaban, and Apixaban are at least non-inferior, and the higher dose of dabigatran or Apixaban are superior to warfarin, and all the novel agents reduce the risk of intracranial hemorrhage. Thank you very much.